Dr. Louis Machogu. I'm the president of the Pharmaceutical Society of Kenya. Of course, you know that I do policy shaping, advocacy, member engagement. I also am a pharmacist. I do capacity building, supply chain, and community engagement through MedKit Network. Today you're joining us for the second part of a four-part series, where today we'll be looking at understanding internal and external pressures that drive change. Disclaimers, I'd like to thank Daktari Online for this platform and availing it to us for purposes of sharpening ourselves, iron sharpening iron. So it's going to be engaging, and you will also have an opportunity for Q&A. The first session was so exciting and engaging. So please, thanks for everyone who was courageous enough to ask questions, even the hard questions, because this sector of ours has many hard questions that sometimes we don't get to ask. So success to me by the end of this is that we're able to ask questions that you even have the anonymous parts that you can even actually slot in an anonymous question, so that you can get clarity. Where are we going? You know, what's happening in our sector? So without further ado, I said I'm a pharmacist at MedKit. What we do at MedKit capacity building, we do market and feasibility assessment for clients, site selection. We have a tool for that. Colleagues who have a startup pharmacy, they've come together, 1-2 people or even one. We have tools for that. And also for people also running pharmacies, we have efficiency tools for this. These are tools that we've been using from the days we were running Halton's Pharmacy, the success and the mistakes we made there. After that, also, we've been doing coaching for private equity investors who have been investing in hospitals and pharmacies, mostly hospitals. And we've used that experience, and we're using it to avail it to all of you who will be willing to use it, so that you know, there's nothing as painful and costly as making a mistake that was known by people next to you. Yeah. We also do supply chain and logistics. This is where we are known. We do sourcing and distribution of medicines, and we do last mile delivery just in time, and also community access and network engagement. We have some expertise in brand building, marketing, and access tools for quality care. That's how you can reach us if you'd like to reach us. And just note that down and just take a screenshot. Reach us when you want to. So we are on a journey, like I said, a 4-part series. As we've kept going, I sort of coined this word, the anatomy of change. Yeah, it's a 4-part series, and for you to be an effective change manager, you have to be aware of yourself. That's what we discussed last week, part 1. Aware about yourself, your reaction, and what do you have that is in control. You have direct control over. What do you have that you have no direct control over? We looked at passive people who respond to change passively. Kazi ya mtu mwingine. Victim, they are the ones who are sabotaging us. A saboteur, someone who actively goes and sabotages the issue. You give them the work, they don't do it, or they actually go out of their way to prevent this for whatever reason. Today we look at those different kinds of people, and they're called stakeholders. Yeah, how do you map them out and engage them? Ambassadors, these are people also who can be champions for the change that you are driving. Today we are looking at part 2, which is we are going through the pressures, internal and external, and drivers for change, yeah, and as well as looking at some of the tools you can use to evaluate, what's the nature of the change that's required, and to what extent do we do this change. Next week we'll do part 3, where we look at how to navigate that change. Now that you are clear of what the change is required, how then do you navigate it? There are various tools, there are communication tools, assessing resistance. We look at all those things next week. Finally, on the 3rd week, we'll actually look at now sustaining that change. So what? Change came. How then do you sustain it? How do you sustain that mindset of change? Yeah. So that's the objective for today. We want to understand the pressures, both internal and external, and the drivers of change. So identify the leading, who is leading change and who can support that change. Yeah, and awareness of the external drivers of the changing pharmacy landscape. Last week we looked at one particular end where I would say that's an internal example. Today we looked at some external examples, and I'll bring in part of that internal so that we can drill down a bit more in a sense, sort of reflecting on what we discussed last week. Identify your role, because at the end you also have a role. Huh? When you look at all the stakeholders, you'd be asking yourself, where am I in all this? Where am I as a stakeholder, and what's the value that I bring? Yeah, as a theory of change. You have a theory of change. You're saying, if we do the following, we'll be far much better than where we are right now. Yeah, and these are the things that we need to do to get to that particular change. Yeah, so let's look at some external change drivers in our sector. Yeah, you have, you don't exist in a vacuum as a profession. They say our profession, any profession, it's given its mandate by the public. The public say, we can't treat ourselves. We are so lazy, we can't even go and study pharmacy for 5 years or the 3 years for diploma, 5 years for degree. We have no that time. Let's get people who, that's their interest, they go do that thing, and we delegate that mandate to as a society. Yeah. So there's a demography. The demography, you actually cannot even call them. You actually have to WhatsApp them. You have to tweet them. You can't give a call, or you leave a voice note. They leave for you a voice note. Yeah, that's so how are you responding to that? You as a healthcare professional, as we become more developed, we move towards lifestyle diseases. The other driver of change externally is a legal mandate, where you have legislation, and I'll talk a bit about this, because healthcare is a social responsibility, and you've had successive governments been talking about universal healthcare coverage. So you wake up one day and the president says healthcare is free. How does that affect you? Yeah, how does that affect you? Or they say healthcare has to be delivered through SHA. SHA is a social healthcare authority. Now you wonder, I as a farm tech, or I as a pharmacist here, yeah, in this profession we are calling pharmacy. How do we relate to that SHA? Yeah, and as you'll come to see later, there are actually 3 funds. Huh? How do you relate to any of those? Are you aware of what is happening there? Geopolitics, Africa CDC has been developed. We are moving towards a unified regulatory, framework, and that's why PPB is moving to maturity level 3, WHO maturity level 3. What does that mean for you? Does it mean you can practice in Kenya? What you've been practicing in Kenya as a pharmacist, can you practice it in Egypt, for example, once you become a unified, or will you have to go back to school? This landscape we are practicing in, you have social influencers who have a skin routine. So whereas in the past that you used to go to the pharmacist to access these services and interact, yeah, you wake up and you find there's a whole person called in that bedsitter somewhere who has a following of 40,000 people. When you yourself, you are a professional there, you are opening your doors, by the end of the day, you've only seen 50 people. How are you leveraging these opportunities where the public is moving towards self-care and where social influencers, are you able to package yourself as a professional and with knowledge and expertise that you can actually avail it through lived out experience? Because that's what they're asking for. You as a pharmacist, what are you using for your skin? What are you using for for this your hair? What are you using? These things like that. Yeah, how are you leveraging that during the downtime of your? So remember, clients, sometimes you are maybe in Syokimau. Customers only come 7 a.m. and 7 to 8 a.m. Then after that, you'll see clients again from 7 to 10 p.m. So this middle part, what are you doing with that period? Yeah, and how are you leveraging some of these? How are you responding to these change initiatives around you? And of course, the last one is reputation. Of course, there are many. I just bundle them together in this way. Reputation. How is your profession perceived? Yeah, like I said, maybe let me put it there on the chat. What are some of the things that your clients say about you've talked to a customer nicely, they say something. One word of what they say. Yeah? Anyone who has ever been told, wewe ni more expensive? What are some of the things that the customers say as a reputation? Yeah. Oh, okay, not about you, about your neighbor. You can say about your neighbor. Or they say, oh, you give very good advice. I'm wondering, you don't charge for these services. I've actually gotten that feedback. You're giving this is useful information, but aren't you gonna charge for it? Yeah. You hear, oh, I can get it cheaper. I come to you for advice, and I go get it cheaper somewhere else. Yeah. There's the whole thing about, when people start seeing that there are fake medicines in the market, they wonder, hakuna watu kwa hii industry who practice. So they see those people in that practice space, then there's a reputational risk that is there. So let's do a quick poll on the chat. Who do you think are the key change leaders who are driving change in our pharmacy sector right now? Internally, externally, who are the people who are driving change? I will say the patient for me. Who else? Just put on the chat there. MOH. The president wakes up and says we need UHC. So MOH has to wake up quickly and start doing something. The clients, yes. MOH is also the custodian of standards according to the constitution of the country. Technology regulator. Regulator, PPB is not MOH. Those are two different entities. PPB is a state agency for the government. Yeah. So the board, the regulator, technology. As you'll see, last week we discussed PPB has come up with some, guidelines. By the way, the guidelines that PPB come up with, are those external or internal? If you're driving change, are those external guidelines or internal guidelines? Manufacturers, I would say they're internal, because PPB is part of us, because we have to do, what do you call that when you are stakeholder participation? We actually, or even us as professionals, we complain, or we say, we are leaving so much on the table. How do we? So then PPB comes together as a regulator. Like I said, PPB is not MOH. It is a state agency that then governs us as professionals. Then we are given safe regulatory status as PSK and KPO on the other side. Yeah, so manufacturers, that's why you are seeing, you wake up one day and clients, all your diabetic clients who have weight issues have moved to Ozempic, Sindio. Yeah, those are now the kind of, that's how, change is driven. So let me just look at the next slide. Let's look at the next slide and look at this together. You all said the patient. Yeah, I had clients. So there's a patient and there are caregivers. And I'll be specific, unpaid caregivers, because they are paid caregivers. Those are called providers. Yeah. So the patient and the unpaid caregivers, you as you have aging parents. They're somewhere. You who takes care of them are their unpaid caregiver, and of course the parent is the patient. Yeah. So that's at the center of all of this, and that's why they're in the middle there. The patient is the center of everything that we do. So then we have providers, medical officers, nurses, clinical officers, nurse practitioners, physical therapists, imaging guys, professional providers, so hospital clinics. You have the level 2, 3, 4, 5, and 6. Yeah, those housed in all those facilities. Those are now the providers. The next one is payers. As you know that 4% of the country is covered by private insurance. Yeah. Then between 18 maybe to 30%, depending on people are they renewing, is covered by NHIF. And we're now moving to SHA, where the government wants to look at everyone is 100% covered. Yeah. They're even looking at how do we make the patients who are not the patient, the public who don't earn salaries. How do we onboard them? Yeah, they're looking at your M-Pesa transactions and seeing, all those things. Yeah, so you have all those are called payers. Who is paying for this service? The payer dictates where the customer goes to get the medicine. So you wake up one day, you are in Malava. You have a pharmacy there. It's doing very well because you are seeing all the teachers, all the police, all these people, because they're coming, they're paying cash and things like that. Then one day, because those are the people with the money in those areas. Then you wake up one day and they say, by the way, we can't come to your pharmacy if you're not in the panel. Yeah. And whose panel? You thought, it was just Jubilee. No, it's the entire country's panel. So the entire country is under a panel. And the panel says that you have to have certain things to, you have to have certain standards to be providing care to these people. So that's who are called the payers. Huh? And that's where the country is going. We are moving to a place where almost 100% of care will be, because it's a social good. It's a social service that needs to be given to the people. And of course, regulators, I heard all of you say regulators. You have the Ministry of Health, government regulator agency, also training institutions. I sort of put them all together there. Then you have the manufacturers, the suppliers, supply chain entirely, yeah? Kutoka manufacturers, mpaka meds, mpaka chems. So now the question becomes, what services are you providing to this ecosystem? Wherever you are, what services are you providing in this ecosystem? So you have to, before you initiate a change or drive something that, I want to open a pharmacy in this place this year. You must have mapped this area and seeing, what are the drivers? How will the customers come? Do they come through the payers? Do they come themselves through their caregivers? Do I target their caregivers? I see mostly children going to schools. Should I partner with the schools so that I have an awareness? Should I do deworming? All those things, yeah, and so on and so forth. Suppliers, where will I be getting my medicines from? Yeah, and so on and so forth. Yeah. So you have to be asking yourself these questions. They're actually repeated, but the essence of these questions is for each of these levels. What professional services? And some of you will say, no, I'm only provide regulatory services to suppliers. Yeah, that's, you're a professional. That's part of you can actually transit from one sector to another after you've assessed and said, okay, why do I need to see the change? I want to make the following change because, and I have a case study a bit later on of how you make such a change, because you're here and you're saying, government is doing something, then I should be ready. Yeah, because you've been saying you don't want to be the one who change has happened, and you're waiting to, you are not aware. So you want to be the one driving that particular change. As you do your stakeholders mapping, you need to identify the stakeholders like we have done here. Yeah. And we did earlier on the chart. You need to establish these stakeholders. What do they have to gain? Yeah. The patient, what do they have to gain? Provider, the payer, the regulator, what do they have to gain in this particular change? You started your online pharmacy. Who's meant to gain there? Yeah. Number 2, establish whether they have power to support or block. I remember I started the first online pharmacy in the country in 2009. It was called drugs.co.ke. So I've run it for a couple of maybe 2-3 months. I used to be based in physically, my pharmacy was in Kenya Cinema. So I had a pharmacy there. I had 2. At that time, we had 2. So I had a pharmacy in Kenya Cinema. Remember I told you we started Haltons with 4 other pharmacists. We were 4, all of us. And so I was stationed in Kenya Cinema. And I remember someone walked in, gave a letter to one of my assistants. I see my assistant shaking. She comes, I look at the letter open. I've been summoned by the Pharmacy and Poisons Board in 2009. Yeah. Why? I'm running an online pharmacy and an agency called Interpol, because online can be accessed anywhere in the world, says someone is running an online pharmacy in Kenya and has access to the US market. I had never sold anything to any US market. Yeah, it was, if anything at that time, if those of you remember in 2009, the internet was so slow, there was no reliability, but we assigned that online pharmacy. It was called drugs.co.ke. So quickly, I had to make some changes on the website because there were images of medicines on the website. So according to Interpol, that contravened some guidelines. Yeah, I was not aware. Yeah, so quickly I had to I was summoned by one of my colleagues who's also still a director there, and I went there and explained myself. So, and that's one of the things. If you're a professional, you just have nothing to hide. You're able to. So I was quickly advised. So I was given supportive supervision. I went and changed some things, but we never moved on with the journey of the online pharmacy. We decided to go with the chaining of the pharmacy, and 2013 up to 2016, we grew. It became the largest chain of pharmacies with 52 pharmacies. But again, change. So we decided to start an online pharmacy. We got some feedback. We saw the technology wasn't ready. We decided to change. The regulator wasn't aware. Now we have the regulatory guidelines on online pharmacy. Telehealth guidelines are there. You can even do teleconsultation. All those things are available. But again, you have to look at who are the key stakeholders and where do you put them. So as MOH, yeah, their level of interest is high and their level of influence is high also, because they can close you down. Yeah. You start doing a campaign about something, you wake up the next day, PBB has shut you down because they have a level of interest, because that's the sector, and they have their power of influence. On the x-axis, you're looking at the power of influence, and on the other side, you're looking at the level of interest. And what do you do about those people? So if you're a patient, for example, I would say your patient is high interest, high influence, yeah, because they can refuse to come. They can even go tell people, other people out there that, hey, uko usiende, yeah. Where do you put your suppliers, for example? Anyone on the chat, where do you put your suppliers? It depends, some suppliers, they are low interest and low influence. Them, they don't care. All they care is, have you paid? Yeah. Another one, their level of interest is high because, they want to know these medicines, when you take them, how do you store them? So you have to keep them informed. Yeah. That's the quadrant where they are. So they have a high interest. Maybe they have no power of influence much, but you keep them informed. But there's some suppliers, by the way, they have high influence. So you have to also engage with them and see, so that they might refuse supply you a certain item and it's popular in your place, and so on and so forth. Yeah. So it's how do you map your stakeholders according to their interests. So whenever you make change, you're not making just for you. Of course, you know that you're gonna, it's gonna change your life. This is good change and things like that. But who is the primary, or who are the other stakeholders? And you have to look at what's in it for them, not in a bad way, so that you can know and how can they influence, so that you can categorize them and know what to do with them. Am I keeping this one satisfied? Am I managing them closely? Am I monitoring with minimum effort, or am I keeping them informed? Yeah. And that's how then you are able to drive this change. So these are some of the tools that you actually use to manage your change. At this juncture, I want to do a small poll with one word. Pick any of these words. Something that speaks to you. How are you currently adding value in the pharmacy profession? You provide care, knowledge. I think all of you, if you're in community pharmacy, you provide knowledge, kwanza for free. Yeah, innovation. Yeah, you're leveraging technology. You are leveraging. You went for training to do deep, injection, vaccination, and even contraception. You are running on efficiency. You support people on efficiency. That's some of the things I do. Support them, patients on care, and supporting the caregiver. You provide, counseling and compassion, education, specific education on, your people come to you for consultation. You just do leadership. You run a hospital. You could be a CEO. You run a department in a hospital. You deal with safety, quality. You have expertise, dedication. How are you adding value? Yeah. You do advocacy like myself, and you could be doing something else that's not here. Let's see it on the chat. Health talks, knowledge. Any guys of quality, safety? Because as we move, you need to understand, it's not just, it's not just what you know. Yeah. It's what do you do with what you know. Yeah. You have all this expertise, knowledge, and information, but how are you availing it out there? Yeah. So that as we move now to discuss value, because what we want to do is we want to transit now to discuss value. How do you package and deliver that value? Last week we see this where we are now to the levels. I would proposed to us are internal drivers. Remember last week we discussed and said we were starting to have the discussion, should we abolish pharmaceutical technology training? Yeah, and the question was because there's two entry points to practice pharmacy at the same level. So as the question was good, maybe you could say, oh, is it targeting one person? But the reason behind could be good, but we need to be careful and engage the question well and honestly, so that we can come and say, we actually have a role for farm techs, we have a role for pharmacists. If anything, even we need specialist pharmacists. Yeah, so that's what now we are moving towards as a nation. We need to know our pharmacy professionals in training, our interns before registration, both pharmacists and farm techs, our farm techs, how many are they? Pharmacists, how many are there? And specialists. And this professional composition is adding value to the profession of pharmacy and the patients. Yeah. How do we get there? There's some things we need to do. Interventions. Yeah. Good pharmacy practice guidelines. It's there. Scheduling of health products and technologies. Costed pharmacy benefit packages is what I want to talk about today, because that's an external change. Remember, an external driver of change. A lot of what we discussed last week was an internal driver of change. Yeah? A national pharmaceutical policy. And what are the outcomes? You have innovation. We have people moving up the cadres, people having resource. Yeah. The reason why I'm a pharmacist and I can't even go do a master's because it costs $1 million or whatever, I can't do it because there's no one to pay me for the services I'm offering right now. I'm even giving counseling and knowledge and all these things for free. Yeah. There's no mechanism or framework. I try to do that by charging. The customer says, wewe ni mzuri lakini ni more expensive. They go somewhere else. Yeah. So how then do we make some interventions in our sector, put some standards so that we are able to, if I started in as a farm tech, I can move up the career, or I can actually be comfortable and say, that's where I want to practice. This is what my level. I'm a pharmacist, this is where I want to be. I'm a specialist, this is where I want to go to. And even, and this is who I want to collaborate. So we have this sort of nyumba kumi that has a complement mix of farm techs, pharmacists and specialists working together for that region. Yeah. And that's how SHIF or SHA compensates them. So you find that the community grows, and then you have all that career progression, and we have fulfilled careers. Yeah. So that's what we discussed, part of what we discussed. Another quick recap. This is the last recap from last week. We also recapped the good pharmacy practice guidelines. Yeah. We reflected on why do we need these levels and the cadres. Why? Because the country is moving towards defining the health facility as per level. So you have level 1, 2, 3, where you have a community health services and dispensary clinics. Who is running? Minimum qualification for a superintendent is a pharmaceutical technologist. Level 3 health centers. Level 4, 5, and 6 you have 4 and 5 you have 3 and 4 you have pharmacists, and 5 and 6 you have specialists. But as we do, you remember there's going to be a graduation. So at the moment, you might find that level 3 still have pharmaceutical technologies, because even you have many level 3s that don't have pharmacy personnel. And then you'll have level 4 and 5 pharmacists and then specialists. But then as we start having more pharmacists, farm techs upgrading, pharmacists upgrading, then now we can actually have that full complement mix. Yeah. Also, community pharmacies are being categorized. I know last week you asked, why are they being categorized? So today we have the answer, because of an external change that has come. So if we don't do this change, the external change will come and demand something of us. Then you'll find the services will go through hospitals and not pharmacies. Yeah. So I'll go to that next. So community pharmacies are being proposed to be categorized as level 2A and 2B. 2A has a pharmaceutical technologist, remember last time, who has just done their diploma. 2B has a pharmaceutical technologist who has done a board certified program. So it could be a person who has done a higher national diploma and things like that as a superintendent. Yeah, but you might still have another. In 2B, you might have it might be so busy that you actually have more than one farm tech. Level 3, you'll have a pharmacist as a superintendent who has done a bachelor's, and then level 4, you have a specialist clinic where you have a specialist pharmacy where you have a pharmacy specialist with now the other complement of staff. Yeah. Then you also have categorization of wholesale. I won't go much into that. Then of course we have the level of hospitals and on the right side there. So that's just a quick recap of what on clinical. The right one you have there is clinical services, and this is the So I know someone is asking there, and you can raise your hand. Why are we talking about services? Yeah, I've been offering services all my life, talking to patients, but no one has been paying me. What is the need of these services? Yeah. So let's go to the next slide. Yeah? I'll come back to that. Let me come to this first one first. Yeah. So there's been an external driver of change. Remember when you start talking about UHC, President Kibaki, President Kibaki did it in a certain way. He empowered hospitals, built hospitals, and all those things. President Uhuru came, he started talking about UHC. It's wakaanza kuongea na community health workers, all those things. Then President Ruto came in, and he came in with an agency called SHA. So of course, there's been court issues like that, but there's one authority called SHA and 3 funds. I don't know if any of you knew any of this. There's one authority. I know you keep hearing SHIF, you hear, but there's one authority called SHA. It is the one who will be responsible for all these things. Primary Health Fund. Primary Health Fund is fund for level 2 and 3. Remember where we said there were farm techs? Yeah. Then you have Social Health Insurance Fund. That is for level 4, 5, and 6. Yeah. Services for 4, 5, and 6. Then you have the Emergency, Chronic, and Critical Illness Fund. That is now for specific things, but mostly 4, 5, mostly 6: referral care, chronic emergency care, things like that. Yeah. But then your question becomes: I have a friend called Dr. and a colleague called Dr. Yakub. He's only, I think, in my opinion, he's the only critical. I don't know of any other one. He's the only critical care pharmacist in the country. He works in Coast General. Now, Dr. Yakub needs to be compensated for his services. That's why there's a tariff for the benefit. And I'll put the link. Let me just quickly copy the link. I put it on the chat because all of you as professional colleagues need to have these documents. You need to look out for these documents because this is what is going to shape your profession. And you need to be having these discussions in objective way. Yeah. Zile siku za fights of pharmacists versus farm tech, those days are gone. Because if you keep fighting like that, what will happen? The hospitals will go with the services. Yeah. You as professionals, pharmacists, because remember your birthright is that degree as a registration certificate. Yeah. That is your birthright. Yeah. So if you're not able to offer services as a pharmaceutical technologist and compensated for the same because it's not there in the tariffs for the benefit packages under the Social Health Insurance Act, yeah, whether for primary health, social health, or chronic and emergency health, yeah. Kama hauonekani hapo, if you're only seen there as product, then you will never be compensated for your service. Siku nenda siku rudi, you'll just be offering your services for free, and the product will be compensated. And who makes when the product is compensated, where does it go? To the company? Yeah, it doesn't go to the professional. Yeah, and then that's why you'll have the situation where all wanyama wote need the same pharmacist, farm tech. It doesn't matter. We just want the cheaper. Then the farm tech never gets a motivation to grow to become a pharmacist. The pharmacist never gets a motivation to grow to become a specialist critical care pharmacist like Dr. Yakub in Coast General. Yeah. So I've shared that on the chat there. So that's why the change is happening. And you need to look, and that's, remember when you looked at the tools, these two particular tool of mapping your stakeholders, you need to look and see who are the people who are driving change. You know, you've been just sitting internally here and fighting and protecting your turf as a pharmacist or farm tech. But then some changes are happening outside there. The customer is changing and moving with social influencers. Yeah. The next thing you hear, SHIF has taken the patient. The next thing, that's a wewe ndo umeachwa hapo. But I think, in my own opinion, and even as we talk with colleagues who are working on these things at PPB, PSK, and KPA, what we are increasingly seeing, this is good for the profession. Because for once, the value of the professional will be seen to you as a professional and even to the patient. So how does the patient or even the employer? So relative to the pay price alternatives, and alternatives I'm looking here, it could be alternative like hospital and pharmacy, or it could be social influencer and pharmacist, it could be pharmacist and pharmtech. What value do you bring to the patient, the payer, and the employer? So there was a colleague, it's a colleague of ours. She's done a master's from abroad. She actually studied abroad, and she came into the country. She got married, had children. Profession is going on there. But you see, the profession out there is different than it internally here in Kenya. Yeah, we shouldn't be embarrassed to say that. That's where we were. You remember, we were here. We need to get to there. How it is there, there's value. The patient services of a pharmacist are seen in a certain esteem, and actually they are started compensating. So during this period, they didn't change their career. They're doing drug registration and all those things. So the other day, as you all know, last year I think pharmacists in the UK were given expanded mandate. So then pharmacists become lucrative. But now, what happens to this colleague of ours now? They start applying for jobs there because you get a visa as a professional, and they are very high demand. So they decide to go there and work there. They move their families. Now they are there. Their husband is a medical doctor, so move there. So they are offering services there. So the question then becomes, nani ameumia hapa? It's a Kenyan patient. Nani ameumia mwingine? It's a Kenyan profession, because there's a perceived value. We haven't really availed it to our customers. So there's a price that's needed to be paid. So who is meant to know this price? It is the payer. Who is meant to know this price? Is the employer. Price in terms of salary. Yeah. Who is meant to know the price? The patient, in terms of, you want to give me a medication reconciliation report. It costs me 2,000 to give it to you. Yeah. Will you pay that? Why is it important? The insurance company needs to know, why am I paying for chronic patients medication reconciliation reports, or for their medicines, because they have like 10 different medicines? Why do I have to pay for the way medical insurance pays for patients to do annual checkup every year? You as a pharmacist, you're given that annual to do that annually. You as a pharmtech, you're given to do the following services at a certain level like that, as per the good pharmacy practice guidelines. Already those services are inside there. Now, should we say all pharmacists and pharmtech do the same services? It will not be. It will not work, because then we are now talking about value based on competence. So you have the following services being, even me as a pharmacist, as I can't do certain services that can be done by Dr. Yakub, who's a specialist. Yeah, because he needs to take responsibility, get an indemnity cover, professional indemnity cover, and offer those services. So that even the employer can see that value and say, so a medication reconciliation report is 2,000. Okay, so let's charge it at 3,000. Then the hospital gets 1,000. You as a profession get it at, or whatever it is. Then we'll get more. You can even pay, do it at 2,000 and split the cost. Yeah, it's up to you. So that's the value that you need to package. And remember, value is relative. Relative because if you send your mother 1,000 to buy ile dawa yake ya hypertension, atakumbuka akilisa kukwambia dawa nini milking salve ya kukamua ng'ombe, inaitwanga nini ile popular, nimesahau, ile wasichana wanatumia kwa skin. Anatoa 500 aenda nunua milking salve. Ananunua nini? Dawa ya mastitis ya ng'ombe. Yeah, because there's another relative thing that they would rather spend their money on. Yeah, they don't spend their money on the medicine you send them as your parent. Yeah, because waliona haya kukuitisha, whatever it is. So even in professional services, kuna kwanga na relative value. The insurance will say, but I get it cheaper here. Why do I have to come to you? So that's why as a sector we need to come together, because the patient doesn't know the value you offer. When Steve Jobs made the iPhone, or Henry Ford made the motor vehicle, he usually used to say this joke where he used to say, if I had asked people what they wanted, yeah, they would have said, we want faster horses. Sindio? So Ford would have become a horse breeding company for building faster horses to pull chariots faster. Yeah, but the people didn't know what they want, because they couldn't even fathom what is a car. And that's why we are saying the patient cannot fathom MTM services. Yeah, and what services are being offered by a pharmacy, even the payer cannot fathom. Yeah, so it's us as a profession to put our house in order and make this change with the patient in mind. Yeah, so that then we can move ourselves in graduated, and then we do referral internally. Yeah, and then we then you grow. Then you feel like this profession imekushika sana, upgrade from a farm tech to a pharmacist. Imekushika sana, upgrade to a specialist like Dr. Yakub, yeah, or Dr. Kagwa, the chair of HOPAC, yeah. Upgrade and go do this so that you can be able to, even you have some esteem for your profession, yeah. So that's really how you have to look at the issue of value. How then do we package? And this value has to be packaged by us as professionals. And that's why when I was given the opportunity by Dr. Online to do this topic on change, I try to interweave it by real things that are happening in our sector that we may not be aware, but you are really concerned about, but no one is there to solve. But now I want to challenge you and tell you, you are the one. Yeah, change starts with you. So how can the pharmacy profession add value to its patients? That's what we are discussing. How are you marketing that value? How are you motivating the patient for the desired outcome? Yeah, we need to move to value-based care. There's a bill coming soon. It's called Quality of Care Bill. That quality of care bill will start rating professionals according to values that you give. Whenever this patient goes to Green Cross Pharmacy or Blue Cross Pharmacy, like that, they come out with good outcomes. Yeah. So then you are compensated more, but it's still in the work. It's at MWH. Yeah? Again, that's something to look out for. Yeah. We talked about this SHA and SHIF. So as you've made your change, you need to evaluate. Yeah. So as we are looking at this change, does this strategy fit with where we are going? So remember, there's before and after. Yeah. And is there a profit to be made in all this? Because remember, if there's no sustainability mechanism, then it won't work. Does the strategy exploit the key resources? We have human resources in pharmaceutical technologies, in pharmacists, and in specialists. Does it exploit? Does it see all these people? If you make a strategy that only see pharmacists, that only see farm techs, that only see specialists, you remember whenever we've had bills happening, KPA goes to parliament, wanna fight just farm tech. PSK goes there, fight just, time has come, we need to fight together. Because today, Nakumicha is there as a CS. Tomorrow, she's not there. But do you know who is there? The profession. Yeah. So we need to start moving in that kind of movement. That is change that is required. And it's who drives when you are there in your AGMs, be courageous to say, where are we with this? Where are we working together? And when you go to parliament, we should be going together. And because we have all agreed that we need to have the levels of practice. We've agreed that we need to have scheduling. Because if we don't agree on that, SHA will come, start compensating services, pharmacy itakuwa tu kupeana madawa. Hakuna services. Yeah. Then you will forever remain a farm tech, forever remain a pharmacist, forever remain you can't even upgrade. Yeah, because there's no motisha, there's no incentive. Will you envision the differentiators be sustainable? Is this going to be sustainable to have different levels of profession in the levels of practice in the profession of pharmacy? I propose yes, because it has been shown that the highest cause of death in the developed world, so the second highest cause of death in the developed world is drug-related problems, injuries or disability deaths from people took medicine, it reacted with this one. They have been taking these 4 different medicines. One has told them, reviewed it. The next thing happened, the patient died or the patient got a complication. Now their kidneys are this way. Yeah, because someone just didn't take their time. So yes, there needs to be these levels of practice, and we have data and we have the advocacy tools. Are there elements of your strategy internally consistent? Is this consistent with what we have mutually agreed on? So we are saying as KPA, PSK, as pharmacists, as farm techs, specialists, pharmacists, have we agreed? Is this are our universities training this way? Yeah, or are you gonna say specialists? Then the next thing the government says, okay, where are these specialists? They are not there. Yeah. Do you have enough resources to pursue this strategy? Yes, the country has enough resources to compensate for this, and it will actually serve the country for every 1 shilling spent. They say they are abroad, for every dollar spent, so for every 100 shillings spent, you are saving even close to 1,000, yeah, out of that, 10 times. 100 times. Did I say 100 to 1,000, 10 times? Is the strategy implementable? This one I'll pose to you as colleagues. Is this thing implementable? Is it just a pipe dream? Yeah. Yes, no. put it on the chat. You can even add your question under if you have a question or concern. Yeah, can your organization can your organization as KPA make it through this transition? Can your organization as PSK make it through? Yeah, or will we remain prideful and refuse? You know the way they say when I don't know if you've seen this picture where there were two antelopes fighting. Yeah, but lion amekatu hapo, just ready to pounce. One of them was eaten, by the way. Yeah. In this case, I think both of us will be eaten because this profession will go with the hospitals. Yeah. Because it will just be about product. Then the way you as a profession, everyone is compensated for services, clinical officers, medical doctors, specialists, everyone is compensated except you. And then your profession will stagnate and even die. Yeah. So I think it's only one person who's confident to say, is this implementable, colleagues? Yeah. Yes, no. Yeah. Because that's now where we are going to. Yeah. Thanks for the thumbs up. So what to do with what you know? So given the realities, yeah. So we are closing now, so that we can do some Q&A. What time do we have? Given the realities in the market, on the jobs, hakuna makazi, roles are mixed up, resources constrained, the country says haina pesa ya healthcare, a changing landscape in healthcare. You've seen the changes both external and internal. Your knowledge and skills that you have gained across to the education and your work experience, you should be asking yourself these two questions. And these two questions are what will take us to the next class, yeah, the next week session. How will I distinguish myself to get the position I want with the salary that I want and the income I desire? Yeah. How will I leverage on the profession of pharmacy? Because remember, it is your birthright. That registration certificate is your birthright. How will I leverage this profession to serve the needs of the patient, healthcare professionals, healthcare system, and society? Yeah. I have those links. Remember last week you asked for the link for the GPP guidelines. It's there. I can actually put this on the chat. Then you have the SHIF guidelines. Also, you have the pharmacist and PharmTech competence framework. I forgot to put that link. But if you go to the PSK website and the downloads, because that's what we use to catalyze the issue of benefit packages. I've been PSK president for the last 7 years. And the thing that we came is I've always been seeing we need to work together in levels. And as my term comes to an end, what you are seeing is the fruit of the work. And I would like to thank our colleagues at PPB for their leadership in that, for our colleagues at HOPAC. They've really been, generous with their expertise, and we've been able to come up with the drafts that now we actually have to pass and prepare ourselves for benefit packages by SHA and SHIF. So at this juncture, that's how we close. We've already done session 1, session 2. 2 more sessions, responding to change and continuous improvement and sustaining that change. Yeah. So let's do question and answers. I said I won't keep you guys. I know it's a lot of content, but I tried to weave it together with the realities on the ground. Yeah? And like I was saying, you can even use the anonymous question button to just ask that hard question. Nini imekuwa ikikusumbua about this profession of ours? And, or even a thought, should we just do something? Just put it out there, because as we do this as your leader, what I do is when I go to these tables and say, this is what is happening. And these recordings, we put them there and we're able to share with the PPB and say, this is what the sector is saying. Yeah. And this is how we need to drive this particular change. Because if we don't, because today we're learning also about the drivers of change, the external drivers of change are so big, because healthcare is owned by the government, by the way. Because if people are not getting well, they are dying, who will be blamed? It is Ruto must go. So the president has said, you must change this thing. Now, you can't sit pretty as a professional and just sit there and say, no, my diploma, my degree, I just sit like that. It will not work. What will happen is it will even become worse. Yeah, all of us will start moving abroad. And I see a question. What are the areas of specialization for a farm tech? Yeah, it's a good one. Let me go back to the slides. Thanks for that question. Here, So you need to look at this slide. And but there is all of you who have logged in, I think you logged in using an email. It will be sent to you by the presentation it will be sent to you in PDF. So you have to go to the good pharmacy practice guidelines. Yeah. Then you look at where you come in. Yeah. Specialization equal at all. I wouldn't say it's the way, because right now the specialization is so there's I have to be careful with that. There's a farm tech. There's a farm tech who has done board certification. So let's follow. Farm tech, there are two types. Farm tech who just did the diploma. Then a board certified farm tech. Yeah, there's a difference. Huyo ameenda kafanya higher national diploma in anesthesiology, si ndio? Amekuja anafanya, and there's a whole list of services services that these professionals can provide, and PPB has that list if you just go to their website. So that's for the farm tech. For the pharmacist, kuna pia pharmacist and board certified pharmacist. So pharmacists who just did their degree, but then who has gone further and maybe did a postgraduate diploma, something else, like a certification on something, and they can offer certain services. So these are those two differentiators. Then there's specialist. Now you went back to the university, did 2 years specialization. You went to abroad, you did a PharmD, and you came back. So you specialize in a certain thing. So critical care, whatever else there is, like that, renal care, look at the entire body, cardiovascular, you can specialize on all these and sit somewhere and offer those services. You can even specialize in what do you call it, surgery. You are there helping the anesthesiologist on managing those infusions into the patient as they are kept under the and even help them with their care after surgery so that they don't have complications and reduce. So that's how you're adding your value. So that's a good question. So there's all these specializations. So there are professional farm tech with the two types, pharmacists 2 types, and specialists multiple types, yeah, according to the different specializations. So, but that is being driven, because when the insurance will be saying, why am I compensating a critical care pharmacist? They'll come to documents, and the documents they'll come is the documents by PPB, the GPPB guidelines, and there are also specialization and all those things that will come, yeah, scheduling, all those things. So they are all on this page. Particular, I'll post the link again. I posted it last week. What are the? Oh, it's the same question. No other question. Let me post this link. I had posted earlier. Actually, let me post them, both of them together. I had posted earlier the 3 guidance, yeah. Good pharmacy practice guidance, that's what was last week. That's document, you need to go look at it. If you're looking at specializations and all those things, it's inside there. SHIF benefit packages as well. Looks at compensating according to, because SHIF will compensate according to the 3 funds. You remember the 3 funds? It's on this page. Primary health fund, social health insurance fund. Primary health, we said, is for level 2 and 3. SHIF is for 4, 5, and 6. Emergency is for 5 and 6. Critical care, like that, yeah. For you as a specialist, for you as a pharmacist who's done board certification, for you as a farm tech, you've done board certification, you can be compensated at that level, yeah. Was there another question? Is this useful? You can just click like or something. Should we continue to endelea ama tusiendelee? I have a concern on pharmacy master specialization. Why is it not open to special? Okay, yeah. And that's a good question. You're finding it is you graduate, it comes out as a general clinical pharmacy master. Yeah, we are saying it will be good for it to be specialized, so that you want to be an expert in a certain thing. So you don't want it just to be a jack of all trades, because people who are expert in particular thing then are even compensated, are compensated in a certain way. Sorry to talk about a lot about compensation, but you also have to, each professional has to also move from just it has some challenges. We know we look. I talk to some farm tech sometimes and say, "Can you upgrade?" I say, "No, cost." I talk to some pharmacists, "Can you upgrade the same cost?" Why are they concerned about cost? Because no one is, and they are offering services. No one is compensating them. Yeah. So we need to move our training curricula, and that's something also under review. Remember, last year some reviews were done, but because there was no proper stakeholder engagement, what happened? It was shut down. So it is one of the things that need to be revived. Our universities need to offer this particular, like if there's a higher national diploma for a farm tech on specific oncology, KMTC will offer you like that. There's a specialization on masters or PharmD with a certain inclination, but the universities here, everyone has been given how to move upwards. Yeah, so that when we go there with our compensation packages, we can actually, pharmacy is a family that has people inside who have incentive to keep growing. And one of the next places, like we said, if you're looking at our stakeholder mapping, we had is we look at the stakeholders, because even PPB is not working by itself. It has to look at the stakeholders here. Number 4, regulator and training institution. So we have to move to that, to a place where now that specialization is really specialization. It's not just a general, I'm a clinical pharmacist. Yeah. Thank you. Thank you for that. I have answered it. Any other question? Kunyamaza labda tuliongea vizuri ama tumeleta confusion. Please write your questions, and what we can do is the next session next week we can start with questions. If you have any questions, Andre from Daktari Online will share these to all the participants, the PowerPoint presentation. This is not a secret. It's for you, to empower you, equip you, and even the videos, within a week's time, they're already posted. Yeah. So you can be able to even go back and look and see, okay, how can I participate in this change as a driver? So colleagues, thank you for the time. Thank you for your interest and paying attention. All 200 of you up to this time. Thank you. I hope I've inspired you, challenged you, and help us move together as a profession.